Yesterday at the International Society of Hematology, we had a well-attended session on plasma cell disorders, and my topic was on amyloidosis. Amyloidosis is a rare disease compared to multiple myeloma. We expect to have like 1 or 2 amyloidosis patients for each 10 myeloma patients, but however, the incidence is not rare compared to, for instance, other diseases such as CML. So it is an important disease. Why? Because the symptoms, if they are recognized early on, it prevents from major organ damage. And it has been shown by various authors that it takes like 2.7 median of 2.7 years until a diagnosis, and more than half of patients visit at least 5 different physicians to reach a diagnosis. So the initial symptoms are usually neurological, and later during the course, GI symptoms and monoclonal gammopathy starts to appear. Cardiological findings also follow, and latest are usually the renal nephrotic or nephritic syndrome that leads to the diagnosis. And for this reason, it is apparent that multidisciplinary approach is needed. And during the last years, cardiologists have become aware of not only AL amyloidosis, but another type of amyloidosis, which is transretinal ATTR type of amyloidosis, and since it is causing heart failure with preserved ejection fraction similar to AL amyloidosis, and the reasons, the cause of ATTR amyloidosis is completely different than AL, where AL is a plasma cell disorder, but ATTR is the transretinal is secreted in the liver, but the mutations in the molecule leads to amyloid deposition. There are 2 types of it, the variant type or the wild type. And one type is epidemic in some countries, such as Portugal, in Nordic countries, and also in Japan, and also among African Americans. And all these both types are usually seen among the elderly, and we see the same trend for the other plasma cell disorders. And this means that we need to recognize these entities and look at the symptoms and also the findings, and search for monoclonal gammopathy very carefully, because, to repeat, I want to underline and highlight the fact that their treatments are different. And with AL amyloidosis in 2021, the paper published in New England Journal of Medicine, ANDROMEDA, led to an approval of a new drug in the history of amyloidosis in more than 10 years. And this is Daratumumab. It is an anti-CD38 monoclonal antibody in combination with the CyBorD regimen. The depth of response, the speed of response, and which is moreover of greater importance, is the organ repair effect that is seen with this addition of this compound. And based on the positive findings of this study, which was for not advanced cardiac failure patients, it was repeated among advanced cardiac failure patients, and the same results were confirmed and presented at the last International Amyloidosis Society a few weeks ago. So now we are very optimistic because many new trials are ongoing, and we have other monoclonal antibodies such as Daratumumab, which is another anti-CD38 targeting agent, and we also have additional monoclonal antibodies which target the light chains, the free light chains, and also the amyloid oligomers. And among these, we have 2 antibodies, which is Scale, and the other one is, which was earlier named NET-001, and is now Daratumumab. And we have new trials with these monoclonal antibodies, and recent month, a firm study with Daratumumab has been launched. And on top, we also have some evidence in favor of CAR T cells in this infectious disease, and also bites are promising. So the field is moving fast, and this is very good news.